Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I have been a cardiologist at the Texas Medical Center for more than 30 years, and today we are going to learn something about management of angina pectoris. Medical, balloon, bare metal stent, drug-eluting stent, coronary artery bypass surgery, and much more. So let us continue. Say you have been following a patient with a known history of a coronary artery disease who has some minor exertional chest pain. You perform a nuclear perfusion imaging to find out what is the extent of his myocardial ischemia and what is the appropriate treatment for that patient based on your non-invasive diagnostic tests, including a complete history, physical examination, electrocardiogram, 2D echocardiogram, and of course the nuclear myocardial perfusion imaging. All right, you have received the nuclear stress report. The nuclear stress report shows there is a small area of reversible defect. Now, here are the options for you. Would you continue this patient on medical treatment? Would you send him for a plain old balloon angioplasty? Would you recommend a bare metal stent? If so, under what circumstances would a patient be selected for a bare metal stent? Would you recommend this patient for a drug-eluting stent, coronary artery bypass surgery? This is a multiple choice question. We always have to have this, all of the above. Would you be considering all of these above options? Or would you say, I'm an internist. I believe in differential diagnosis and the treatment depends on what the condition is. Or would you just reassure the patient and follow up in 3 months? These are very valid and complex questions. There are no simple answers to these questions, but in the next several minutes we're going to look at the merits and the demerits of each one of these treatment modalities in managing patients with stable or changing angina pectoris. So let's look at some of these options. Let us say this patient comes back with more or less a normal looking nuclear perfusion imaging. Or let's say this patient has a small fixed defect. Or let's make it a little more interesting. Let's say this patient has a small reversible defect. What do you do next? Well, if the reversible defect is of a small size, then it is reasonable to treat these patients medically, optimize their medical treatment, modify their lifestyle behaviors, and see if the patient improves. If the patient improves, you continue with the treatment and reduce the risk factors. If the patient continues to have symptoms, then you proceed to the next step, which is coronary angiography and coronary intervention if it is necessary. What are the drugs available for treating a patient with a stable angina or mild exertional angina with a history of hypertension and little hyperlipidemia? These patients can be treated with sublingual nitroglycerin if the patient is getting an occasional chest pain with moderate exertion. They can also be maintained on isosorbide mononitrate. The beauty of isosorbide mononitrate is this is long acting and it can last up to 24 hours. But sometimes it may be wise to take the smallest dose that is needed so that the patient can function normally. The isosorbide mononitrate comes in 30, 60 milligram dosages and it can be given once a day. Just like with sublingual nitroglycerin, they may also experience some headache, which is usually treated with acetaminophen. The next group of drugs are, of course, beta blockers. The most frequently used beta blockers are metoprolol and atenolol. If they are already on these drugs, we can increase their dosage to make sure that their heart rate stays in the range of 50 to 60 beats per minute, thus decreasing the myocardial oxygen demand and also bringing their blood pressure down. All patients with known coronary artery disease need to be on high intensity statins such as atorvastatin or rosuvastatin in probably maximum doses. We also need to control their blood pressure. If we control the blood pressure, many times the patient's symptoms improve automatically because we are reducing the afterload, thus improving the myocardial function, which can bring down the symptoms of myocardial ischemia. Similarly, treatment of diabetes is of paramount importance because diabetes is a major risk factor for coronary atherosclerosis. Weight reduction would certainly help if the patient has especially gained weight in the last several months. Weight reduction will reduce the amount of cardiac work needed to carry that extra load. So, along the lines of weight reduction, an exercise program will also help to improve the coronary collateral circulation and thus minimize the symptoms of ischemic heart disease. Once we control the blood pressure, the blood sugar, and the symptoms of chest pain and bring down the cholesterol levels, the remaining risk factor becomes number one, that is smoking, because this is a risk factor which can be easily modifiable. By encouraging the patient to stop smoking, we can dramatically reduce the risk of heart disease. 1 year after the cessation of smoking, the risk of coronary artery events decreases to that of patients who are non-smokers. So there is a tremendous benefit in encouraging the patients to quit smoking, especially when they have a history of diabetes, hypertension, and heart disease. Similarly, alcohol consumption should also be moderate, no more than 1 to 2 drinks per day, preferably wine, which might help patients with history of coronary artery disease. So this is a brief overview of medical management of patients with exertional angina who doesn't need any aggressive diagnostic tests or interventions. Now let's move on to the next scenario. Now let's assume you have a sort of a moderate size reversible perfusion defect. The left ventricular function is normal, and you decide to send this patient for coronary angiography and possible coronary intervention. Under what circumstances would we use a plain old balloon angioplasty? In the era of drug-eluting stents, the plain old balloon angioplasty is taking a back seat, but it is not totally out of the picture. So, under what circumstances would we consider using a plain old balloon angioplasty, or POBA as it is called? When we do coronary angiography and we see some of the branches having lesions that are critical, but the size of the artery may be so small where we may not be able to get a stent in place. If the artery size is less than 2.5 millimeters, it may be difficult to get a metal stent in that region, and in those circumstances we may just do a plain old balloon angioplasty. Another situation where we may be just happy to do a plain old balloon angioplasty is a lesion that is so hard and calcified it is next to impossible to get the metal stent. And if we cannot get the stent, but if we can get the balloon across the lesion, then we just use the balloon to open up the blockage and hope for the best. The plain old balloon angioplasty, which was the first thing that was done when the coronary intervention was introduced into the field of cardiology, does relieve symptoms. But since we are using plain old balloon angioplasty in smaller and smaller arteries, the restenosis rate is high. And also, balloon angioplasty or even stent placement does not prolong life. It simply is a symptomatic relief of angina. Now let's look at the bare metal stent. Again, we go back to the same question. When we have drug-eluting stents, which have a much better patency rate, why are we using bare metal stents in patients with coronary artery disease? Let's look at a nuclear perfusion image here. We got a big inferior wall reversible defect. We have an anterior wall reversible defect. When you see a sizable amount of defect, we know we are dealing with a major coronary artery or one of its branches. So when we get into that situation, we are tempted to put a stent at the lesion and leave the stent in place. So we have a choice of bare metal stent or a drug-eluting stent. The circumstances which will force us to use the bare metal stent are generally the patients who come for cardiac clearance for a general surgery or an intervention or a procedure. Then we find out they have reversible defects like these, and then we do the cardiac catheterization. Then the question comes, do we put a bare metal stent or a drug-eluting stent? If this person cannot go for an entire year on dual antiplatelet agents, and if this person needs the surgery or the procedure within the next several months, then it is reasonable to put a bare metal stent, maintain these patients on dual antiplatelet agents for at least 4 weeks, and then proceed with the surgery. While we are talking about surgical interventions in patients with coronary artery disease, the same principle applies to people who undergo balloon angioplasty, who also need to be maintained on dual antiplatelet agents. But the advantage in a patient with plain old balloon angioplasty is that 2 weeks after the procedure, we can stop the antiplatelet agents. The patients can go through the emergency surgery or intervention and then resume the antiplatelet agents as soon as it is cleared by the surgical team. So getting back to the bare metal stent, one scenario where we would use bare metal stent would be in patients who need some urgent surgical intervention in the immediate future. Bare metal stent and drug-eluting stents, they all have the same prognosis in terms of relief of symptoms. They do relieve symptoms. The patient's quality of life improves, but they do not prolong life, and there is always a chance of stent thrombosis. Patients who receive bare metal stent have a much higher degree of in-stent thrombosis, ranging anywhere from 30 to 50% in some cases. And because these patients are on dual antiplatelet agents, they also have a tendency to bleed from time to time. Is it reasonable to put multiple stents in these patients? This question becomes more relevant in the next slide when we are talking about drug-eluting stents. Let's talk about drug-eluting stents. In an ideal situation, if we have a patient with a definite abnormal myocardial perfusion imaging study with reversible defect involving a large segment of the myocardium, then it is reasonable to consider a drug-eluting stent. Drug-eluting stent has several advantages compared to a bare metal stent, in that the rate of restenosis is considerably less and the symptom relief is almost similar. One of the disadvantages of a drug-eluting stent compared to a bare metal stent is that these patients need to be on dual antiplatelet agents for a minimum of 1 year and perhaps longer. And if they have to go for surgery, they The surgery has to be postponed for at least a year before we can stop the dual antiplatelet agents to clear the patient for surgery. Instant thrombosis is also a problem, but the incidence of instant thrombosis in a patient with a drug-eluting stent is something like 0.5% per year. That's a very small number, but however, when it happens in a given patient, it can result in an acute myocardial infarction. Of course, we have the problems with bleeding related to dual antiplatelet agents, and a question always comes up: is it reasonable to put multiple stents in patients with triple vessel disease or in patients who have concomitant other medical problems? That's where the differentiation between the drug-eluting stent indication and the coronary artery bypass surgery indications come into play. So let us move to the next slide, where we talk about coronary artery bypass surgery, and this will give us a much better understanding as which patient is suitable for surgery, which patient can be treated with drug-eluting stent. If we are dealing with a patient with a history of diabetes mellitus, especially if we are dealing with a patient with a reduced left ventricular function, if we are dealing with a patient who has triple vessel disease, or if we are dealing with a patient who has proximal left anterior descending artery and the critical right coronary artery disease, especially if they have one of the other conditions such as reduced ejection fraction or diabetes, these patients do better by undergoing coronary artery bypass surgery. Their symptoms improve, their quality of life gets better, and only coronary artery bypass surgery has been shown to prolong life. That is an important and pertinent point that differentiates coronary artery bypass surgery from drug-eluting stents. Overall, patients who receive coronary artery bypass surgery, especially the LEMA, which has a almost 85 to 90% patency rate after 5 years or even 10 years, get excellent results. Similarly, the saphenous vein grafts also improve circulation, but more and more people are using even the right internal thoracic artery to bypass the right coronary artery or the posterior descending branch. These patients, because of their high risk, which includes diabetes mellitus, triple vessel disease, reduced left ventricular function, they are maintained on dual antiplatelet agents, but there is no compulsion to continue them for a minimum of 1 year before these patients can undergo elective general surgery. If we need to stop these medications, we can stop them, and after the procedure we can resume the medications. No matter what we do, whether we do a plain old balloon angioplasty, bare metal stent, or drug-eluting stent, or send this patient for the ultimate coronary artery bypass surgery, the medical management is still the foundation upon which all these supplementary procedures are added on. What I'm trying to say is, it doesn't matter what procedure you undergo, you need to be on this foundation of medical treatment to optimize your medical management, minimize the myocardial work, improve the quality of life, and reduce the cardiovascular risk factors. So, ladies and gentlemen, this is a brief overview of how you approach a patient with coronary artery disease who has mild symptoms or moderate symptoms, how you diagnose, differentiate them into different categories, and choose the appropriate treatment based on the coronary anatomy in combination with all other medical problems. I am Dr. Nik Nikam. Thank you so much for watching, and we will see you next time.